Today, I am speaking to Dr. Guy Ringler, who is a partner from California Fertility Partners in Los Angeles, California. Welcome.
Thank you very much. I'm happy to be here.
And we are talking about male fertility health, especially during Pride Month and for LGBTQ plus family building. So as it's June, we wanted to cover the topic of LGBTQ plus family building, but also talk about how men can optimize their health for fertility. As you may know, often there's a lot of emphasis around the women, and so it's a good time to be speaking about the men as well. So the first question I have for you is, what male fertility tests should men be looking to have, and how far into the kind of trying to conceive process would you advise this happens?
Great question. I think heterosexual couples trying to conceive, 50% of couples, there will be a male factor component. So it's not strictly female, not strictly male. So I think from the very beginning, part of the basic infertility evaluation for heterosexual couples should be a semen analysis. For gay couples who are planning to have children, the very first thing should be a semen analysis. For most guys out there have never had a semen analysis, and so they don't know what it is. And it's important to do it early, because if there is an abnormality and we might need some treatment to try to improve the sperm, it can take several months to see an impact of that treatment. So I always recommend to get it done early. Fertility is impacted by age. I think we're going to talk about that a little bit, but it's also impacted by lifestyle, environment. So there's a lot of influences can impact a man's sperm count, his sperm quality. And so we want to identify a problem early to see how we can improve it if we need. What I do when I help couples with their fertility treatment, I try to optimize each variable. So we want to try to get the best quality eggs. I want the best quality sperm. We can optimize their chances of getting pregnant. So it's not, oftentimes it's not a quick solution. It's a long-term project. And so we want to identify problems early so we can address those.
Great advice. And I've spoken to so many people in the community who have maybe gone 6 months into the process, longer, heterosexual couples, and then found that actually the problem lies with the man after the female being investigated. So as you said, it's key, isn't it, to have tests done?
Yeah, and I hate when I hear that. And sometimes men might be reticent about getting a sperm test. Maybe they're feeling a little shy, they're a little awkward. They don't want to get it done. But it does provide very important information to prepare for the semen analysis. A man should abstain from ejaculation for 2 to 5 days to give the laboratory the best possible sample. And it may take a couple of specimens in order to diagnose the problem. Sperm numbers can fluctuate from sample to sample. So in order to diagnose a male problem, you need a couple specimens, a couple different tests to truly pinpoint a problem. Mm-hmm. When we do a semen analysis, which is the basic test that I've been talking about, it gives us several pieces of information. It's going to give us information on the volume of the ejaculate, make sure it's within normal range. Then we're going to look at the sperm count, which is expressed as million of sperm per ml. So it's the concentration of sperm. The next parameter we look at is the sperm motility, the percent that are swimming. The third most important parameter is the morphology, the shape of the sperm heads. These three parameters, the concentration, the motility, the morphology, correlate with the ability of the sperm to penetrate an egg, which is a true sperm function. So if any or all of these parameters is decreased, the sperm will have a decreased ability to fertilize an egg. So the next step is to discuss treatment to help improve the sperm function. Mm-hmm. In most fertility treatments, whether we do an intrauterine insemination to help the sperm or IVF to more directly help the sperm, we start with the sperm wash. Sperm wash simply is removing the sperm from the semen, and it's going to separate the good sperm from the not so good sperm, the sperm that are dead, that aren't moving, that may entangle the good sperm. We're going to wash those away and we end up with a concentrated solution of the highest quality sperm. And that wash sample is then used for the intrauterine insemination, which places sperm higher up in the reproductive tract. Or we can do IVF, where traditional IVF, you place sperm in a petri dish with eggs to allow it to fertilize naturally. Or more often, if there's a sperm problem, we'll use assisted fertilization. It's known by the acronym ICSI, which stands for intracytoplasmic sperm injection. In this procedure, the embryologist isolates a specific sperm, one sperm, and under the microscope, injects it into the egg to facilitate fertilization. So sperm that may not have the ability to fertilize on its own, we can achieve a near normal to normal fertilization rate of approximately 70%. So it's an excellent treatment option for men with low sperm numbers.
Fantastic. Thank you for that. What about male fertility and age? Is there a decline in fertility when men reach a certain age, like there is with women?
Women and men are impacted by aging. In women, as they get older, the number of eggs remaining decreases, and the quality, the genetic makeup of those eggs decreases, so that there's a greater chance that the egg has chromosomal abnormalities. Men are also impacted by age. Men over the age 40, we start to see some decrease in sperm parameters, decrease sperm concentration, motility, a decrease in the volume of the ejaculate. There's a growing body of data on the impact of male aging on the offspring. We know that in men over age 40, there's an increased incidence of autism in the children. There's increased incidence in certain genetic diseases related to the impact of aging on the genetics of the sperm. There's epigenetic changes in sperm that can increase disease, schizophrenia, other problems in the male offspring. So it is better for men to reproduce at a younger age, but more and more Americans and people around the world are putting off having children until they're a little more established in their career. So it affects men as well as women.
It's good to hear more information on that, because I don't feel like there is as much education around that topic as there is for women. And
I think there's been a lot of focus on women and reproductive aging. We've learned a lot more how to evaluate it, and we're trying to develop ways to improve upon it. There's been, if you look at the big picture, less research on male reproductive aging and male fertility treatments in general. Men are more protected by aging in that they continually to reproduce sperm. A woman is born with all the eggs she'll ever have, and every month a new group is recruited, one ovulates, and some are wasted. Men do have the capacity to generate new sperm, but what is the impact on aging on that sperm quality? And when we look at sperm counts in general for men around the world over the last several decades, we've seen a dramatic decrease in sperm production. Sperm counts are decreasing, motilities are decreasing. We're not sure what all is causing this. Environmental toxins, lifestyle changes, diet, especially in America, where we have a problem with obesity, has a negative impact on sperm production. And the foods that men eat can impact sperm production. Our fast food diet, eating processed foods, foods high in trans fats, and just a high calorie diet, all can have negative impacts on sperm production and sperm quality, because it causes something called oxidative stress, which is bad for sperm quality, bad for sperm function. And we see increased amounts of sperm DNA fragmentation, which can lead to infertility as well as increased risk of miscarriage. So we're learning a lot more on the impacts of sperm health, and how that affects fertility. So I think it's great that we're talking about it today, so we can talk about what we can do to improve upon it. And I think what's unique about sperm is that it takes 70 to 90 days to fully mature sperm. So any treatment intervention we're going to do, you have to give several months. So if we're going to give men vitamins, supplements, antioxidants, you have to allow a sufficient amount of time to see an impact. So for individuals who want to get pregnant now, you may not see a quick turnaround.
You mentioned obesity, you mentioned America, obviously there's obesity in other countries too, but are there any trends showing from different cultures, different regions in terms of male health and sperm and depending on different lifestyles and different foods that people are eating?
Well, we do know that diet can impact, a man's sperm quality. There are studies showing that a Mediterranean style diet that's much cleaner with good fats instead of trans fats, which have a negative impact, a stressful impact on sperm production. Good quality fats, polyunsaturated fatty acids, and your omega-3s can have a beneficial impact on sperm parameters. And so there are some elegant studies showing an impact, which we need to talk more about so men are motivated. We all want ourselves to be in great shape. We want to take care of our skin. You have to take care of your sperm. I think skincare is a good analogy because, many people buy face creams, Retin-A's to try to regain our youthful appearance. And that's a long-term project. It takes months to years to see an impact. The same with sperm, changing your diet, allow at least 3 months. There was a beautiful study last year published that looked at the impact of 6 weeks of a Mediterranean diet and its influence on embryo production in IVF. And they showed that as short as a 6 weeks time course, they saw an impact on embryo development of couples that were randomized to the Mediterranean diet, which is Mediterranean diet involves good fats, fruits and nuts, vegetables. So it's a healthier version, which is impactful.
And oily fish as well.
And oily fish.
And would you recommend that men take supplements as well to boost their vitamins and health prior to trying to conceive or during the process?
Absolutely. Yeah, when you make these dietary changes, it's all to improve the amount of fats you're getting and the fibers, which foods that are high in antioxidant activity, but it may not be sufficient. And so it's always helpful to take additional vitamins and supplements that have antioxidants to further improve the environment for your developing sperm. So when you look at sperm vitamins supplements, they usually contain a whole list of vitamins and antioxidants. So it makes it hard to isolate each specific factor and to say which one is causing the positive impact on sperm. But in general, they'll have vitamin C, vitamin Bs, a little bit of vitamin E, coenzyme Q10, L-carnitine, all to help improve the environment where the sperm are developing. The fats are important because fats are components of the sperm membranes. The sperm membranes are important in the fertilization between the sperm and the egg. So the good fats have a positive impact in allowing the sperm to function.
You recommended starting these changes 90 days before treatment or trying to conceive, ideally.
Ideally, any little time, I've seen impact after 30 days. When I examine a couple, when we do a semen analysis, when we find an abnormality, the first thing I'm going to do is put them on some sperm vitamins and supplements. And oftentimes we'll also refer them to a reproductive urologist. A reproductive urologist is a urologist who specializes in reproductive medicine and fertility treatments. And here in Los Angeles, we have some of the top reproductive urologists in the world, that do fantastic work in helping men improve their sperm counts. If they don't have sufficient sperm in the ejaculate, they can obtain sperm directly from the testicles that we can then use in an IVF process with ICSI.
Absolutely. My husband had a urologist and had the microtessi operation whilst I had IVF in conjunction. So I am familiar with that. And yeah, as you said, it's amazing what things are being done in the field to help men who may not have been able to be helped however many years ago. Now, we talked a bit about foods and diet. What about exercise?
Great question. Exercise in moderation is helpful for both men and women. Increases blood flow to the pelvic organs that can help promote healthy eggs and sperm generation. Excess exercise, though, may not be beneficial and may actually be harmful. Guys who work out 7 days a week often have decreased sperm parameters, decreased sperm motility, decreased sperm morphology. It may be related to the increased heat in the testicles generated during aggressive workouts. Anything increasing heat in the testicles can have a negative impact on sperm production. So I always recommend to avoid steam rooms, jacuzzis when you're undergoing fertility treatment, and avoid those excessive workouts. Professional athletes oftentimes have low sperm numbers related to their very aggressive workouts. Women who exercise a little too much, it can impact the hypothalamic pituitary axis, resulting in irregular ovulation, irregular hormone production during the menstrual cycle, which may not be helpful.
Mm-hmm.
So moderation, excellent. Excessive can be harmful.
So avoid ridiculous amounts of cycling and hot baths and hot jacuzzis.
I prefer, 3 to 5 days per week. 6 and 7 days a week is a little too excessive.
And also, it's a short time span of your life, isn't it, to make those changes?
Yeah, well, you're still getting the benefits of exercise by working out 3, 4, maybe 5 days a week. I'm sure your muscles can be helped by having a rest day once in a while.
Definitely.
Repair that damage you've done.
And talking about things to do to improve the sperm naturally, which we've just touched on, what about moving into fertility treatments? What are the treatment options for men who are in same-sex couples and also heterosexual couples? So we've sort of mentioned azoospermia and sperm retrievals. Could you start from the beginning and talk us through the process of what kind of options people would be looking at if there is an issue with the sperm?
Yeah, well, as we mentioned, the initial test would be a semen analysis, and based upon the results, you may perform some hormone testing to try to identify what the problem is. And I usually do this in conjunction with a reproductive urologist. For moderate decreases in sperm numbers, for a heterosexual couple, we'd be talking about a trial of intrauterine insemination, in which we do a sperm wash to help select the best sperm from that sample. We place the best sperm higher up in the reproductive tract, which is what the intrauterine insemination, or IUI, is doing. And we would try that for several cycles. For more severe male factor, which is the sperm concentrations are very low, the sperm motility is very low, the success rate with intrauterine insemination is going to be very low. So we would move directly to IVF, in vitro fertilization, with ICSI, intracytoplasmic sperm injection, where we can more directly facilitate fertilization. With intracytoplasmic sperm injection, the embryologist isolates the best quality of sperm, a single sperm, and under the microscope injects it into the egg. By injecting the sperm into the egg, we're bypassing several steps in the natural fertilization process, which this compromised sperm may not be able to carry out, and we're able to achieve a high fertilization rate of 70-75%. So now that the sperm has fertilized the egg, the sperm is almost off the hook, and that we've gotten that job done. But now we're going to look at embryo development. And embryo development, the formation of a blastocyst, which is a sphere of 1 to 200 cells, that usually occurs on days 5, day 6 of culture. That's influenced by the egg quality as well as the sperm quality. So in some men with a severe male factor, we'll see a decreased blastocyst formation rate related to the sperm quality. Some men with low sperm numbers have increased DNA fragmentation. Men with increased sperm DNA fragmentation have lower fertilization rates, lower blastocyst formation rates, and ultimately lower pregnancy rates. Now, over the last couple of years, there's a new technique available to separate out sperm in a sample with lower DNA fragmentation. The semen sample is placed through a special chamber, this obstacle course that the sperm has to literally swim through, and is able to separate out sperm with lower DNA fragmentation in the sample. Because if a man is found to have high DNA fragmentation, it doesn't mean that every sperm sample is impacted. So if we can separate out the good sperm from the not so good sperm and do ICSI with the low quality DNA fragmentation sperm, the highest quality sperm, we can achieve better success rates.
And what's the technique called for this, for the sperm DNA fragmentation selection?
There's a special chamber, it's called Zymot, Z-Y-M-O-T, and it's a special sperm separation chamber that's readily available, and it is definitely a great new treatment option for men with severe male factor. The routine semen analysis, as we talked about earlier, looks at sperm concentration, motility, morphology. A sperm DNA fragmentation test is a newer sperm assay that will look at the amount of sperm DNA fragmentation. So we don't do it routinely on all of our male patients, but men with a significant male factor, we always look at sperm DNA fragmentation to see if we need to address it. It can be improved by our dietary changes, our antioxidant supplementation, and more directly by isolating out the best quality sperm through the Zymot sperm separation.
And do you offer the Zymot technique at California Fertility Partners?
We do, yeah. We were part of some of the initial research using this separation technique, and we've been using it for several years now.
Fantastic. And I presume that you have patients coming to you from all over the world for what, you know, for your state-of-the-art lab and for the specialist treatment that you can give to people who have such difficulties.
We do. Our practice has been in existence for nearly 40 years now. It's founded by Dr. Richard Mars, one of the pioneers in IVF as a clinical treatment option. So our IVF program, our IVF lab, has been credited with helping to create some of the world's first IVF babies. So over those decades, we've always attracted patients from around the world who come to us for our high quality care, our state-of-the-art fertility treatments, and for treatment options that aren't available locally, such as egg donation, surrogacy, gay family building. We have a very diverse patient population that come to us from all over the world. And I love our international patients because the science is always interesting, fascinating. When we treat patients from other countries, it adds a cultural level that's always fascinating and interesting. And
definitely.
So
that brings me on to the next question to ask you, which is around LGBTQ plus family building, and we're especially talking about this during Pride Month. So what are the options for same-sex male couples, and what are the success rates and the wait times and the costs involved in that?
Thank you for asking. I've been helping gay men to have babies for about 25 years now.
Wow.
In fact, one of my first couples was from the UK 25 years ago. The treatment for gay men who want a baby of their own involves using egg donation into IVF using the eggs from an egg donor, combined with gestational surrogacy. So we create the embryos using donor eggs and the sperm of the intended parents. We freeze the embryos, and then those frozen embryos then transferred into the uterus of the gestational carrier, the surrogate mother. California has always been one of the safest places in the world for surrogacy because the laws are very defined, very well established, and very protective of the rights of the intended parents. So when the baby is born, the baby is, the legal parents of the baby are the intended parents. Laws, contracts are placed in place, filed with the state. So when that baby is born, the intended parents are the true legal parents of the child. Surrogate mothers are very carefully screened. They're very committed to the process. they're they're very proud to be surrogate mothers. They're really amazing women around the country, not just California, who are committing a year of their lives to helping others become parents like they are.
Mhm.
So it's a fun process. The success rates are very high because really these are the best possible conditions to initiate a pregnancy.
Mhm.
We have the high quality eggs provided by our young egg donor. The egg donors are usually in their mid 20s, and we're creating embryos, culturing them to the blastocyst stage. We may or may not do genetic screening, pre-implantation genetic screening, and we're putting these high quality embryos into the optimal environment that the surrogate provides. The surrogate is a woman with no history of prior infertility. In fact, she has the opposite. She has proven fertility. She's had one or more pregnancies that were normal, uncomplicated, and of course, her thorough medical screening minimizes the risk of there being any chance of a high-risk pregnancy. And we have wonderful egg donor options in the United States. I work with multiple different egg donor agencies to provide my patients with the diversity of candidates. So you can look for someone, whatever you're looking for, someone of the same family heritage, same educational level. I always advise my patients to search until they find someone that they feel really excited about, they feel really good about. And then she undergoes a complete medical screening. She'll undergo psychological screening, genetic carrier screening. She'll have an interview with a geneticist to review the family tree, looking for any history of disease that may have a genetic influence. Once she's completely medical screened, then the egg donor undergoes the IVF treatment process. So the treatment she undergoes is the same as a woman with infertility undergoing IVF. In the beginning of the menstrual cycle, she starts daily injections of hormones, and those hormones are stimulating the development of all the eggs that she's recruited for that month. Not 11 or 12 days later, we perform the egg retrieval. The eggs are inseminated with the sperm. If we have a gay couple, we divide the eggs into equal groups and do half with partner A, half with partner B. Embryos are cultured, oftentimes biopsied for PGT and frozen. And once we have our embryos frozen at that point, the intended parents will be matched with the surrogate mother.
And so the first process after the testing is to find an egg donor prior to finding a surrogate or matching with a surrogate. Is that correct?
Correct. 5 to 10 years ago, we would never start a treatment process until we had a surrogate in place, because we always wanted to transfer a fresh embryo into the surrogate mother. Today, in most high-quality IVF labs, the pregnancy rates with thawed frozen embryos are the same as fresh. So in our program and many others today, we create embryos, freeze them, and then the intended parents are matched with the surrogate mother. And most surrogacy agencies in the US today won't match you with the surrogate until they know you have embryos frozen and ready.
Mm-hmm. And in terms of the egg donor sort of search time, I presume that is slightly less than matching with a surrogate. Is there a long waiting list to find a surrogate?
It could take 1 to 6 months to be matched with the surrogate. There's obviously increased demand over the last several years. So it used to be 1 to 3 months. May take a little bit longer now. Multiple different agencies, so my patients can make a choice of the agency they prefer to work with. And then the agency, once a candidate is available, usually they wait until they have several candidates. So they give patients an option of which candidate they feel most comfortable with.
And if they want to have future siblings, would it be possible to use the same surrogate again a couple of years later or however long later?
Yeah, it's not uncommon for my gay patients to ask their same surrogate if she's willing to carry another pregnancy for them. In most cases, the intended parents and the surrogate develop a special relationship. They become good friends. And so it's not uncommon a couple of years later for the surrogate to offer to carry for their next pregnancy if they're planning more children. And in the egg treatment process, our goal is to generate a sufficient number of embryos to achieve a pregnancy by but also to have some extra embryos as backup if we need them to achieve the first pregnancy, but hopefully so they can add to their family in the future if desired.
And if a surrogate is chosen and the embryos or some of the embryos get to blastocyst stage and the transfer happens and there is no implantation or there might be a miscarriage, at what stage would you advise the couple or the solo parent looking for a new surrogate?
If we have a negative pregnancy test or biochemical pregnancy or miscarriage, we always have a follow-up call, Zoom call, and to review everything to see if we can identify what may have been the cause, see what we might be able to improve upon. The standard of care has been after 3 embryo transfers without an ongoing pregnancy to change surrogates, just to change one of the variables. Even though we're transferring high quality eggs provided by the egg donor, even if we're transferring a genetically normal embryo, there's still a chance it may not work. There's still a chance of miscarriage. After the transfer of a genetically tested embryo, the miscarriage rates are decreased, but there's still a 10% miscarriage rate. The genetic testing gives us a lot of information, but doesn't tell us everything. There could have been a subtle genetic defect that was not tested by the PGT. There could have been a structural abnormality with the embryo, not allowing it to implant. So if we have a negative pregnancy test, review all the data, see if any changes need to be made to try to improve conditions for conception, plan an additional transfer.
And it's not just for same-sex male couples surrogacy, is it? It might be for people seeking solo parenthood, men seeking solo parenthood, or heterosexual couples who aren't able to carry the baby for whatever reason.
There's many reasons to pursue surrogacy. As you mentioned, heterosexual single couples. I have more and more single men who decided to become a parent on their own. And for heterosexual couple with a medical need for surrogacy, had women who've had a hysterectomy due to cervical uterine issues and required gestational surrogacy. Women with a severe medical condition in which a pregnancy would be a danger to their health, surrogacy is an option. Some couples with recurrent miscarriages, surrogacy provides a more optimal environment for carrying the pregnancy to term. Some couples with unexplained IVF failures with multiple embryo transfers without a success, thought to be due to implantation failure, surrogacy is an option. So we do see patients from around the world who seek us out for surrogacy as part of their medical treatment to help them to have a baby to start their family.
I, in fact, heard from a couple yesterday who are heterosexual who are trying for a second child, and the woman sadly had cancer. And so the chemotherapy has meant that she's not able to carry another child. So they do have embryos stored, but they're starting the process of looking for a surrogate and trying to work out which country to do it in. And of course, America is a top choice. One thing I wanted to ask you, which comes up a lot, is what do the costs look like for surrogacy and for egg donation, dependent on your situation?
Well, the one downside of surrogacy is it does take a significant financial investment. The combination of egg donation and surrogacy together will run somewhere between $150,000 to $200,000, and we try to keep the cost contained. But in reproductive medicine, which is high-tech medicine, the costs keep going up, and what the amounts that the individuals are paid continues to increase. During the treatment process, we do all that we can to optimize the number of eggs produced, the number of high quality embryos. From the medical perspective, most of the costs are related to creating those embryos. Once you have the frozen embryos, the costs related to a frozen embryo transfer are significantly less. So we try to do all we can to optimize embryo production.
And are there any sort of finance options for people who don't have this covered on insurance or can't pay for it outright? Is there any way of kind of staggering it or doing it in a more cost-effective way?
We do see some creative companies today offering insurance benefits to their patients that cover fertility treatment, including surrogacy and gay family building. There are a few finance programs available. One's surrogacy program in the United States, that's a new finance program. Some patients seek help from their parents. I have had young gay couples whose parents really want grandchildren.
Yeah.
And so they're financing the treatment process for their son and son-in-law. Does take a little bit of creativity. I'm part of a nonprofit organization called Men Having Babies that has a scholarship program for needy intended parents, and that's a way that may help shave down some of the costs.
Fantastic. Thank you for those resources. We've talked a bit about egg donation, but in terms of choices, when a couple or an individual is seeking an egg donor, what kind of choices do they have, especially in the States?
The choices are unlimited. When you start looking for an egg donor, there's egg donor agencies. Most surrogacy agencies today have an egg donor program, and you'll start by looking at pictures, profiles. Where the U.S. is a very diverse country, so you can really find whatever you're looking for in terms of family heritage, educational level, hair color, eye color. Some donors are completely anonymous. I think about half the donors today are willing to meet the intended parents. So that's an important decision you need to make. So if you know that you really want to meet your egg donor, so you will be able to make the introduction to your children someday, you should tell the egg donor agency, only show me your egg donors who are willing to be open. And you'll look through multiple photographs, personal statements. We have fertility consultants available that can help you do the egg donor search. I have assistant within my office who will help you navigate the egg donor field to help you find an egg donor. Mm-hmm. And you should really search until you find that special someone. This woman is going to provide the genetics of your children. And so there has to be some connection, something that reaches out to you by her profile, her image, her personal statement. And I hear from patients all the time that, I was searching and all of a sudden this one just speaks to me. And this is the individual that I would really like to help build my family with. Mm-hmm. And I always tell my patients, you took time before you chose your spouse. Take time to select your egg donor. Mm-hmm. They have to have that special ingredient for you. And then she has to pass all of our medical scrutiny, of course, because I want to make sure she's a good medical candidate. She's going to make a sufficient number of eggs. If she's donated previously, the agency can give us information on how well she did, how many eggs she produced, how many embryos were created, and that can be very helpful information. So take your time, find the right individual, ask your doctor to review that profile, to review the data before you make the final decision. Because our goal is to help you get pregnant. I want you to get pregnant the first time. And so egg donor selection is a very important part of the process.
Do many people share an egg donors?
Occasionally it'll happen. It can be a little tricky because, as I said, we want a sufficient number of eggs to generate enough embryos to get pregnant and some as backup. So for my patients, I like the egg donor to produce between 20 and 30 eggs. It may sound like a large number, but 20 or 30 eggs, if we're planning on doing genetic testing, at the end will give us somewhere between 4 and 8 genetically normal embryos. So if we have two gay couples that want to select an egg donor and she's making 30 eggs, divided by 2 again for each intended parent. And there's always a risk of some individual being compromised by not having enough. Mm-hmm. So I think it's an egg donor cycle, but I have done it on certain occasions with donors with excellent track records of high number of eggs, preferably when we just have one sperm provider, not two.
To your point about the egg donors, you mentioned PGT. Why would you need to do PGT on embryos if the egg donor is of a young age?
When we do PGT on embryos from an egg donor, we find that about 30 to 40% of those blastocysts are abnormal. And it can vary from 20% to as high as 70%. So even young women, some of those eggs in that treatment cycle are going to be genetically abnormal. So PGD allows us to identify those that are clearly abnormal and separate them because they can look like a beautiful embryo morphologically. So for us, it helps in the selection of the embryo. If 30% are abnormal, that means 60 to 70% are normal. So most of them are normal. So it's an option. It's not a necessity.
Mhm.
It does tell us the gender of the embryo. So many of my patients would like that information as they plan their family. They're planning to having 2 or 3 kids. They would like to have a variety of genders. And so they like having that information available.
Well, thank you so much, Dr. Guy Ringler, for all of that incredibly useful information today. And if anyone would like to get in touch with California Fertility Partners or speak to Dr. Ringler directly and have a consult, then I'm linking up the details here. So please feel free to reach out to them, or you can come via Fertility Help Hub and we can put you in touch.